I am Dr. K.K. Agarwal, President of HeartCare Foundation of India, Group Editor-in-Chief of MedTalks, President, Confederation of Medical Association of Asia and Oceania, and past National President of Indian Medical Association. Specific greetings to doctors from Ghana, from Syria, Leon, and from Myanmar, and also obviously from India. This is an international CME where 4 countries are participating and interacting with each other. Thanks to Mr. COVID. Mr. COVID has given us an opportunity to what we call them as in India, Vasudhaiva Kutumbakam, that the whole family is one, the whole world is one. More and more we are interacting, more and more we are learning from each other. There was a time when there was a COVID phobia. Everybody used to say, oh my God, COVID has come, we have gone. People used to think COVID means death. COVID has much less mortality than SARS and MERS, but it is much more infectious. So I always say, somebody says, I have COVID, I say, so what? He says, I have fever, I say, so what? As long as you can reduce the mortality, remember, the mortality is not that high. The mortality is highest in European countries because they have hyperinflammation state. The mortality is second highest in North American countries because they also have hyperimmune status. The mortality is lower in Asian countries, and amongst Asian countries, it is lowest in Singapore, Hong Kong, Korea, and second lowest in India, Bangladesh, Myanmar, Malaysia, Pakistan, etc. In African countries, the mortality is still on the higher side. But this COVID now has taught us so many things that today we have started talking about prevention, also reducing death in the COVID. And there comes cellular physics, cellular chemistry, cellular anoxia, cellular metabolism, cellular immunity, cellular nutrition. And when we talk about that at a level of cellular, always we talk about nutritional supplements. All over the world, people are talking about immunity. Today, we'll focus on zinc. Our focus will be on zinc. Zinc deficiency is linked to taste and smell abnormalities, and 20% of COVID patients have smell and taste abnormalities. B, zinc deficiency does not allow hydroxychloroquine to work better. And we know hydroxychloroquine today is the mainstream of treatment, specifically if the patient has high ESR, high CRP, and high ferritin. C, we are looking for cellular immunity, and we know zinc deficiency makes us deficient in T cell and B cell function. And today we talk about we need a good innate immediate immunity, and we also want a good cellular immunity before our IgGM and IgG antibodies are formed. This session is supported by Indus Life Sciences, who has been promoting zinc-containing nutritional supplements for the last 15 years in Ghana, Myanmar, and Sierra Leone. The purpose of this webinar is to reinforce the significance of zinc in various clinical conditions. Zinc assumes even more greater importance during COVID-19 treatment, as it is an indispensable element to boost the immunity, which is the need of the hour. So our hypothesis today is zinc deficiency, is it linked to smell and taste? B, can zinc be an important part of immunity? C, can zinc added to hydroxychloroquine reduce mortality? And for this, we have an expert who will be talking about it before we interact, and that is Dr. V. Rama Subramanian. He is a senior consultant, Department of Infectious Diseases, Apollo Hospital, Chennai. He is the director of Capstone Clinic in Chennai. He is a professor of infectious diseases at Sri Ramchandra Institute of Higher Education and Research. He is a member in the advisory panel to the government of COVID-19 management in the state. Dear colleague, I present to you Dr. V. Rama Subramanian. Let's listen to him and then we will interact.
Thank you, Dr. Agarwal, for the kind words. The topic I'm going to present today is titled Clinical Perspectives on COVID-19. And I shall have a disclosure saying that we are aware of this COVID-19 only for the last about 6 months. And there is still a lot to be learned about this condition. Our knowledge keeps improving on a daily basis. And in spite of what we have tried as several agents in the treatment of COVID-19, we still find that none of them as yet can be said to be definitely beneficial in the management of COVID-19. So in other words, we are still using most of the treatment modalities as part of a trial context rather than a definitely recommended therapy. The coronaviruses are a group of viruses which we have known for over 5 decades. There are alpha, beta, gamma, and delta coronaviruses, which typically cause a cold-like symptom. So the common cold, one of the viruses which is responsible is the coronaviruses. The first time a great mutation was seen was in the year 2002, when we saw the SARS outbreak, which started in Hong Kong and spread to several countries, resulting in almost 8,000 people being involved, and of whom about 800 died. So almost 10% of people died due to this outbreak. The second time the same coronavirus mutated led to the MERS outbreak, or the Middle East Respiratory Syndrome outbreak in 2012. Now this time, both SARS-CoV-1 and MERS outbreaks started from bats. Bats are asymptomatic to coronaviruses. Subsequently, for SARS, it passed through an intermediary, which has been identified as the civet cat. In the case of MERS, the intermediary was the dromedary camel. From the camel and from the civet cat, the infection passed on to humans, resulting in the SARS and the MERS outbreak. Now, the MERS was far more fatal than the SARS and led to a mortality of almost 35%. The third mutation is what we are seeing now, the COVID-19, which is caused by the SARS coronavirus 2. This virus again started in bats, asymptomatic bats, spread probably through the pangolin, which is an exotic animal, which was sold also in the wet market in the city of Wuhan. This was a seafood and a wet market in the town of Wuhan in the Hubei province of China, where it is believed that this virus started infecting men, probably in November 2019. From pangolins, humans got it. And the difference is that similar to SARS and MERS, the coronavirus, which normally infects only the upper respiratory passage, now has gained ability to infect the pulmonary cells, resulting in pneumonia, which leads to death. The case fatality rate can be as high as 15%, but in general is in the region of 1% with regard to COVID-19. This table is a comparison between the COVID-19, MERS, and the SARS, and you'll see that most of them have similar symptoms in the form of fever, dry cough, breathlessness, maybe sore throat and diarrhea. All of them are viruses which enter the respiratory passage and subsequently have the ability to involve the lungs, leading to mortality. The SARS-CoV mortality here you see is about 2.9%. The MERS can be as high as 37%, and the SARS, which came out in 2002, about 10% mortality is seen. It is transmitted mainly from infected individuals through the respiratory droplets, which a person may cough, sneeze, or even during loud talking or singing, the droplets may come out. the virus is adherent to these droplets, and this can travel in general about 3 to 6 feet. Though sometimes due to a violent cough or a violent sneeze, the virus may travel up to 15 to 20 feet also. Generally, the virus does not travel beyond 3 to 6 feet. So if you are 6 feet away from any individual, you are deemed to be reasonably safe from catching the infection. Most of the infection is directly through this. There is a small percentage of people who get infected through fomites. Fomites are inanimate objects. So if I cough or sneeze, the droplets fall on the table. If somebody touches the table and takes their hand near their nose or mouth, they can get it. Similarly, if I cough, my hands are contaminated with the COVID virus. And if I touch a telephone and somebody else uses the telephone or a doorknob and touches their face, this can spread. So this form of spread is likely to be less common. The main modality is through direct transmission through droplets. A small percentage of cases can also be due to airborne transmission. There are some very small droplets to which the virus may be adherent to, and this may travel through the air and can go beyond 10 or 15 feet as airborne transport. And this is typically seen in the healthcare environment when certain aerosol generating procedures are done. Nebulization, mechanical intubation and ventilation, cough induction, suctioning of a patient who is on a ventilator, all of these procedures can cause aerosolization and formation of very small droplets resulting in airborne transmission. The importance to understand this is that your normal surgical mask, which will block only droplets to a certain extent, and you need an N95 mask if aerosol generating procedures is done for the patient and you are in the vicinity of such procedures or patients. This is a comparison between the flu and COVID-19. Both of them are respiratory diseases transmitted by droplets. If you look at the infectivity, what we refer to as the R0. R0 refers to the number of patients whom a single case can secondarily infect. If one person has the flu, he can infect 1.3 more persons. So the R0 is 1.3. COVID-19 or SARS coronavirus is much more infectious. One person can spread it to 2 to 2.5 people. So the R0 can be as high as 2.5, which means it is far more infectious than the flu. The incubation period or the time taken for the virus to develop in the body after the person is exposed before he manifests symptoms of the disease is about 4 days for the flu. But for the COVID-19, it can be anywhere from 2 days to 14 days. The median is about 4 to 5 days of incubation period. Hospitalization, less than 2% of people with flu get hospitalized, whereas 20% of people with COVID-19 may require hospitalization. And the case fatality rate is less than 0.1 or up to 0.03 or 0.04 for the flu. For COVID-19, it is probably 10 times higher, about 1% or so, and this can increase in the elderly population. It is believed that through droplet nuclei, the virus can enter the respiratory passage of anybody standing close to an infected person. It divides in the upper respiratory passages during the initial phase when the person remains asymptomatic. But up to 2 days before the onset of symptoms, the person can be infectious to others because of active multiplication in the respiratory tract. The virus may subsequently go down to the lung and attach to the lung parenchyma through the ACE2 inhibitors or the angiotensin converting enzyme 2 receptor, thereby infecting the lung and causing a patchy viral pneumonitis. If you look at the pathogenesis, as I said in the initial phase, the difference between the SARS virus and the COVID-19 is that the person with a SARS infection, after manifesting symptoms, it takes about 4 days before he becomes infectious to others, thereby giving us time to isolate the patient and block the transmission. Whereas with COVID-19, the person becomes infectious even 2 days before manifestation of symptoms, making it very difficult. We have to track the contacts so that we can ensure that they are quarantined if necessary and they are monitored. So it is very difficult for public health experts during COVID-19 because the infectiousness is even before the symptoms start. The upper airway is infected, and then once you get pulmonary infection, as I said, the viral pneumonia, this leads to hypoxia, which in the initial phase, the patient is unaware of. It is also referred to as happy hypoxia or silent hypoxia because the patient is unaware. He does not even complain of breathlessness, but if you check his saturation, it may be around 80 or 85. So this leads to a severe impairment of the air exchange in the lung, leading to hypoxia because of pulmonary involvement by the virus. But it is also believed that more than direct action and destruction to the lung tissue, the hypoxia is due to dysregulation of the cytokines. What is normally pro and anti-inflammatory, the balance is impaired. There is a significant increase in pro-inflammatory cytokines, leading to a damage to the lungs, which is actually the reason why some people develop a cytokine storm and they can collapse. The clinical manifestations are typical of all respiratory illnesses, which is cough, fever, sore throat, body pain, fatigue, malaise, headache. This may progress on to pneumonia and breathlessness. It is believed up to 80% of people have mild or moderate disease, which does not even warrant hospitalization. About 15% end up in the hospital outside the ICU, and about 5% may require ICU admission and ventilation. Mortality, as I said, is about 1% or less, but this increases in people who are elderly. 3% of people may also develop diarrhea or other GI disturbances. Clinical studies have also shown that skin changes can happen, loss of taste and smell as high as 20% of cases. They may also complain sometimes of neurological changes. You can get a myocardial infarction associated with COVID. In other words, it's a systemic illness, mainly manifesting with lung signs typically, but can involve other organs also, either directly or through cytokine dysregulation. The median incubation period is 4 to 5 days. And in general, if you are safe for at least 2 weeks after exposure, then it is unlikely that you have got the infection. These are the signs and symptoms. You will find that fever is seen in up to 85% of cases. Cough is about 70% of cases. Dyspnea happens in up to 30 to 35%. Fatigue, body pain, sore throat, headache, chills, runny nose, nausea, vomiting, and diarrhea. And the warning signs which one needs to look out for is fever with symptoms lasting more than 5 days, which may progress to difficulty in breathing, fatigue, hypoxia, and probably hypotension. In general, the disease progresses that for the first 4 to 5 days, the person may only have a low-grade fever, a bit of a sore throat, and maybe a slight cough. This may progress on to a high-grade fever with worsening throat pain. The person may start developing breathlessness after 6 to 7 days. A small percentage of about 5% may end up on the ventilator by day 10 or day 12. In others, the mild hypoxia may last for 4 to 5 days. And in general, in 14 to 16 days, the fever settles, the person improves. But in people who are sick, they may take 4 to 6 weeks to recover. It is also believed that the virus can be cultured in respiratory passages for up to 7 to 10 days in general. And beyond 10 days, there is no active replicating virus. Thereby, after 10 days, the person is generally not deemed to be infectious to others. If you look at the laboratory findings and the radiological findings, you have leukopenia, lymphopenia, there is prolongation of the prothrombin time, there are coagulation abnormalities, an elevated LDH, elevated liver enzymes and CPK, raised creatinine. The C-reactive protein is typically elevated, though the procalcitonin is normal. there is an increased neutrophil lymphocyte ratio. So the absolute neutrophil count divided by the absolute lymphocyte count expressed as a percentage, if it is more than 3.13, it is believed that the prognosis can be worse. So in patients who have lymphopenia, which is severe, the prognosis can be poor. Chest X-ray shows patchy, especially peripheral infiltrates. Sometimes pleural effusion can be seen. The CT scan shows again patchy peripheral ground glass opacities, which may progress to a crazy pavement pattern. In children, typically a reversed halo sign is seen. The ultrasound can show some atelectasis and progressive consolidation, especially in people who are breathless. These are X-ray pictures in severe cases of COVID, and the CT scan, which shows typical peripheral ground glass opacities and a patchy pneumonia, which, as you see in the upper films, progresses to crazy pavement and extensive consolidation with severe hypoxia. The comorbidity is what is more serious, in the sense that even though all of us are equally susceptible to get the infection, people who are elderly can have an increased mortality. On the left side, you see that people in the ages of 60 to 70 have a mortality of about 4%, whereas people over the age of 80 years, the mortality can be as high as 15%. Outcomes are also poor when other comorbidities are present, which include cardiovascular disease, diabetes mellitus, hypertension, chronic respiratory disease, and other immunocompromising conditions. How do you diagnose this problem? The gold standard diagnostic test is a nasopharyngeal with or without an oropharyngeal swab for the RT-PCR looking for the COVID-19 or looking for the SARS coronavirus 2. Now, this has a sensitivity of about 70% through the nose and about 60% through the oropharyngeal swab, which means that almost 1/3 of cases can be missed if you do only these swabs. The sputum has a higher sensitivity of almost 80%. And if you do a bronchoalveolar lavage or a lower respiratory specimen sampling and do a PCR, the sensitivity can be as high as 90%. Apart from the nasopharyngeal swab test, we have rapid antibody tests, which are serological tests which detect the IgG and the IgM antibodies. But like all antibodies, it may take time for these antibodies to develop and be detected. So even in a symptomatic patient, it may take over a week before the antibodies become positive. A word of caution, the nasopharyngeal swab, which is the gold standard, may remain persistently positive for anywhere from 2 to 6 weeks in some patients, because in patients who are recovering, they may be coughing out lung tissue or lung secretions which may contain the virus. But this is, please remember, non-viable virus. So the presence of a positive SARS-CoV RT-PCR in persons beyond the 14 days after start of symptoms is more likely to demonstrate dead virus rather than live virus. In general, it is believed beyond 10 to 14 days, the person is no longer infectious. These are categorization for clinical benefit: mild, moderate, and severe. Mild is those who have mild upper respiratory symptoms, and testing may or may not be considered. Testing is recommended for people who are elderly, people with comorbidities, or people who are healthcare workers where the risk of transmitting to others is higher. Moderate is when the saturation drops to less than 94%, tachycardia, tachypnea, and hypotension. And severe is when the saturation in room air drops to less than 90%. These people may require intensive care because of other factors like myocarditis, severe respiratory depression, and hypoxia. Now, treatment, a lot has been tested. The studies quite often use those agents which we had experience with and which we had been testing against the SARS virus of 2002. And we have tried to apply the same for the SARS coronavirus 2 also. In spite of a number of agents which have been used, starting from antivirals like oseltamivir, other antiviral agents, remdesivir, favipiravir, most of them have not very clearly shown to have a definite benefit in improving the outcomes. The one which is showing reasonable promise is remdesivir, but even that we don't have definitive evidence and there is no statistical significance. Among the non-viral agents, what is believed to be immunomodulators started off with chloroquine, hydroxychloroquine. We have also used anti-HIV drugs like lopinavir, ritonavir, and we have also looked at favipiravir and immunomodulating agents like steroids, interleukin-6 inhibitors. But unfortunately, there is no categorical evidence to say that any of these are definitely beneficial. We are also looking at the importance of elements like zinc, vitamins like vitamin C. But even though these have been proven to be very useful and beneficial in improving immunity and improving your fight against viruses, data against SARS-CoV-2 is still not robust. You will see that the general management includes mainly isolation and infection control, bed rest, adequate nutrition, ensuring hydration and intake output balance, monitoring the patient, and imaging studies. For symptomatic treatment, antipyretics are recommended. Oxygen, starting off with a nasal prong, a face mask, a rebreathing mask, high flow nasal oxygen, non-invasive ventilation, and finally, mechanical ventilation should be resorted to. In general, if a person ends up on a ventilator, the mortality can be upwards of 50%. Some people say as high as 90%. This slide shows the various agents, the antivirals like lopinavir, ritonavir, remdesivir, favipiravir, oseltamivir, and other agents like hydroxychloroquine with or without azithromycin, anticoagulant therapy, which is the new kid in the block because it is believed that there is microangiopathy and hemostatic abnormalities which lead to microthrombi in the pulmonary secretion, which may contribute to hypoxia. So we are using either prophylactic or in some cases therapeutic anticoagulants. And also, as I said, tocilizumab, which is an interleukin-6 antagonist and inhibitor to suppress the chemokines or the cytokines to reduce damage due to the cytokine storm. There is a discrepancy where there is an increased presence of pro-inflammatory cytokines, including IL-6, which can lead to damage, especially in the lungs. And the cytokine storm can also lead to severe multi-system involvement with renal failure and cardiac failure also. People are now looking at concentrating on improving the immune system. Since we are not able to find any definitive antiviral therapy, we are looking at how we can modulate the immune system to ensure that the body fights the infection better. Some of the agents which have been tried include micronutrients and supplementation with vitamins, and this is now gaining strength. If you look at the various agents which have been tried over the last several decades, we find that vitamin A enhances the immune response, especially against viruses like influenza. It is also seen that vitamin D, which has some effect on the innate and the adaptive immune response. And there is also been shown that deficiency of vitamin D leads to increased respiratory viral infections. We have also seen that vitamin D deficiency is associated with probably an increased risk and a poor outcome in patients with tuberculosis. Vitamin C has long been perceived as an important factor in the antiviral response, starting with cold viruses, and high-dose vitamin C has always been advocated in improving the immune response to cold and other viruses. There are several trace elements like selenium, the deficiency of which is associated with increased viral infections. Copper, which definitely has antiviral properties, which has been used even in surfaces to minimize bacterial or viral propagation as part of infection control activities, and also magnesium. These are elements which have been tried and shown to have definite evidence in improving the immune response. Now, coming to zinc, there is definitely a boosting of the immune system with zinc. This has also been shown where there is deficiency of zinc, there is an increased susceptibility to infections. And especially viral infections and zinc have a very close interaction. Zinc is an essential trace element which is important for growth and development and also for maintenance of immune function. Like other elements, zinc deficiency has been associated with an increased susceptibility to viral infections. The zinc status of an individual is a critical factor influencing immunity against viral infections, and people with zinc deficiency have an increased risk of infections. Now, we have tried to adapt and put this in situation of COVID, where by increasing the zinc through extra intake, we can ensure that the outcomes with COVID infections are better. This is because zinc has an impact on viral entry, on fusion, replication, and viral translation. There are several papers which are available on the role of zinc supplementation, how it impacts the immune response, and how we can minimize, especially in children, but also in others, the prevention of viral infections. This is available for the past several decades, and we are now looking into the role of zinc specifically to do with COVID, and initial results are promising. We still have to wait to see whether there is a specific improvement in response against COVID, but I think we shall probably find out soon enough. These are early studies which show that zinc can probably inhibit coronaviruses, and the mechanisms have also been worked out in this paper, which was actually done against the SARS virus. So the potential role of zinc in COVID-19 pandemic is promising, especially because of what we have gleaned over the last 3 to 4 decades. And now, currently, most patients, at least in India, are offered zinc and vitamin C supplementation as part of the management protocol against COVID-19 or for the management of COVID-19. Next is moving on to see what else we can do with regard to managing patients with COVID. We have seen the medical management, but what we also need to remember is the infection control aspects to ensure that the patient doesn't transmit it to others in the ward, and similarly, the healthcare workers are also kept safe. The most important are the 5 moments of hand hygiene as per the World Health Organization. Hand sanitization or washing before coming into contact with the patient, after coming into contact with the patient, before any aseptic procedure, after a procedure, and after contact with the immediate environment of the patient. If hands are visibly soiled, you have to use soap and water. If hands are not soiled, an alcohol-based hand rub of at least 60 to 95% potency should be used. On top of that, if you are treating patients with COVID, personal protective equipment should be appropriately used. If you are looking at an outpatient scenario, these are the points to remember as part of the new normal. Always screen the patient by telephone when they call for the appointment and delay any non-urgent visits. Consider using telemedicine. Recommend home quarantine or isolation for those who are symptomatic if face-to-face evaluation is not necessary. Consider alternate routes of entry and exit and waiting areas in your outpatient areas to ensure that people are safe. Implement respiratory hygiene and cough etiquette, whereby when you cough or sneeze, you do so into the crook of your elbow or into your shoulders so that you don't splash the droplets around. Have personal protective equipment, including surgical and procedural masks, readily available, and limit the number of patients in your lobby or waiting room with appropriate physical distancing. As part of our approach against COVID, we need to educate both the staff and patients. Every person should be treated as a possible COVID carrier, symptomatic or otherwise. Standard precautions, appropriate personal protective equipment usage, self-monitoring is important for all healthcare workers. If we develop a fever or a feverish feeling or body pain, we need to stay away from work, because coming to work increases the risk not only to others, healthcare workers, but also to patients. Environmental disinfection is also an important part of infection control against COVID. With regard to patients, they should be educated about the importance of physical distancing, hand hygiene, cough etiquette, the concept of universal masking. Everybody wearing a mask, even if physical distancing is not feasible, minimizes the risk of transmission and acquiring the infection. Quarantine is also an important part of patient education. When you use the mask, please remember that the mask should be removed and discarded if soiled, damaged, or hard to breathe through. We should not touch the mask, and you should always handle it by the elastic or the tie. If by mistake or we happen to touch the mask, always use hand hygiene immediately. If we are leaving the patient area, we need to leave the mask and probably change the mask. The masks can be worn, a disposable mask can be worn for up to 4 to 6 hours unless it is soiled. And an N95 mask also can be similarly used for up to 6 hours. Recommendations for reuse of masks, especially the N95, are coming up, mainly because we are running out of supplies. So either leaving it in a breathable paper bag for 4 days or subjecting it to plasma sterilization or ultraviolet sterilization is also accepted form of reusing these N95. This is a recommendation from the Ministry of Health and Family Welfare from India, which looks at the various personal protective equipment which healthcare workers, receptionists, and other people in an outpatient setting have to use so that they stay safe. Please see that most of it involves only a triple layered mask, except that an N95 may be needed if aerosol generating procedures are done. A glove is not mandatory as long as you wash your hands or use alcohol gel. It is also important that environmental disinfection is done after each patient and periodically, especially in your outpatient chambers. The staff should be trained. They should have a cleaning protocol in place, and very important to keep in mind what is called the contact time. The SARS coronavirus is an enveloped virus which is very easily destroyed. Even common solution of household bleach of about 0.1% is very effective. So you need to spray, first of all, before you put the disinfectant, you need to clean the area or use soap and water to remove the organic matter. If it is clean, you can already use the household bleach 1% solution. Have a contact time of at least 30 to 60 seconds before you wipe it down. If there are large blood or body fluid spills, you need to use a 0.5% solution of bleach. For linen and mattresses, 5% Lysol would suffice. And if you're using toilets or ambulances, a 1% solution of household bleach is what is recommended. We are now ensuring that as part of public health, we are putting in measures to ensure that we flatten the curve or decrease the exponential growth of the virus in several countries. This is brought down by lockdown, by the government, ensuring that everybody wears masks in public, stays physically distanced, wash our hands, do not engage in physical contact, cough etiquette and hygiene. By all this, we can ensure that we minimize the spread of the viruses. When you're opening doors, please don't use your hand, because your hand may be taken to your face and it may spread. So use either your elbow or your back. If you are pressing a lift button, use your elbow instead of your fingers. If you are on the escalator or stair, do not lean or touch on the banister, stay separate. And if you are handling a mask, do not handle the front of the mask. Always use the tie or the elastic if you handle the mask. These are simple things which you can do. So finally, as practice points, what you all need to keep in mind is that every person could be having COVID, and you need to treat everybody with some basic minimum precautions so that you don't get it and the person doesn't transmit the infection to others. Do not panic. Even though it is highly infectious, the mortality is still low. Most people do not even need to go to the hospital. Ensure physical distancing, universal face mask and hand hygiene. Do the basic investigations to rule out common conditions like dengue, malaria, bacterial infections, so that you don't miss them thinking it is only COVID. Treat all patients symptomatically. You may need to do basic tests, including a chest X-ray, to decide if they require other medications. Counseling on infection control is very important to the patient and the family. And also remember patients who may have come into contact with the index person even before the symptoms start. So in summary, in the absence of proven pharmacological status for prevention and treatment of COVID, a healthy immune system seems to be the best way we can fight this infection. Important vitamins and trace elements have a role, and we are still investigating the role, and zinc and vitamin C are appearing very promising. Zinc is also considered as an adjuvant therapy in the treatment of COVID-19 when you use any of the other agents as part of a trial context to help improve outcomes. So I think it is time we learn to live with the corona. This is something which is going to be around for the next several months or a year or longer. It appears that the vaccine will not be available for at least a year. So in the meanwhile, whether it is the first wave or the second wave, we need to put in place systems so that we stay safe, we keep our family members safe, and we keep our patients safe. Thank you very much.
Thank you very much for a lucid presentation, which I think should clarify everything about COVID to all our fellow countries. Whether you are in Ghana, whether you are in Myanmar, whether you are in any other place in the world, you should be able to get an overview. This program is live on YouTube. You can watch it later again and again. Forward it to as many people as possible, because you will not get a presentation like this again. Before I take up the questions, Dr. Rama, I want to emphasize, I am currently the president of Confederation of Medical Association of Asia and Oceania. We have been discussing about COVID in our Asian countries. So we, for the time being, we don't want to call about what is happening in US or what is happening in Italy. So we found this virus misbehaving, I'm not saying behaving, misbehaving multiple ways. In most of the situation, it behaves like a simple virus. Therefore, they have high lymphocyte count like a normal virus. It has normal ESR, no acute phase reactants. And if this virus comes like that, it will go away without any problem, either asymptomatic or mildly symptomatic. In some cases, it is behaving like HIV. Therefore, it is causing lowering of CD4 cells along with lymphopenia. And if it is causing CD4 cell and lymphopenia, maybe when the treatment came that anti-HIV drugs, lopinavir and ritonavir should be added. Probably they added it in patients with normal lymphocytes and they could not get the better results. I think people can think upon, if you get low CD4 count with lymphopenia, you can add anti-HIV drugs, not otherwise. It is causing hyperimmune inflammation. So it is causing rise in ESR, CRP, and ferritin levels. And that means there is a destruction of cells. And whenever there is a hyperimmune function, in these cases, hydroxychloroquine, which is anti-inflammatory, for fever, indomethacin, colchicine likes of drugs, may be given. And if you are giving hydroxychloroquine, you may have to give it for a longer period of time. And we are seeing this hyperimmune response more in Europe because you are having a secondary manifestation. That means after 3 months or 2 months, you are getting a hyperimmune syndrome in children or a Kawasaki-like presentation. Maybe it is precipitating underlying immune inflammation. Maybe in such cases, chloroquine may have to be given for a longer time. It is causing thromboinflammation in many people, and which is now being noticed at the onset of anoxia. You have microthrombi. Therefore, at the onset of hypoxia, which is silent, you may like to give a low molecular weight heparin and oxygen together. Remdesivir also has been proven to be effective if it is given at the onset of hypoxia. And in other cases, it is causing cytokine crisis where IL-6 inhibitor may be effective. Maybe that we can differentially decide about the treatment based on the investigative findings, that which drugs will act in which, because at this moment, people are trying all drugs in all situations, we may not get the right answer. So therefore, if you have a triggering point, that means on 6th and 7th day, if you have hypoxia, give them low molecular weight heparin, give them oxygen, and give them remdesivir if it is available. If the patient presents with leukopenia, maybe HIV group of drugs may be better. And if the patient presents with acute phase reactants, maybe a long-term chloroquine may be the answer. Do you have any comments for this?
It sounds logical, but as I said, right now, there are a lot of studies going on. What appears very beneficial today appears ineffective the next week. So there is a lot of confusion among all the agents. A lot of them have shown good promise, including hydroxychloroquine, including ropinavir, including interferon, in alone or in combinations. But so far, we have not had a major study which has put a thrust on the importance of any one. So I think we will have to wait a little more before we get clarity in this situation.
And do you think that silent hypoxia is the killer, specifically in the Asian countries? If you detect silent hypoxia in time and give them early oxygen and give them a low molecular weight heparin there, you may be able to prevent mortality in Asian countries.
Yes, as of now, it is believed that the longer the person is in hypoxic state, the greater the risk of poorer outcomes. So if we can detect hypoxia early, start oxygen supplementation, then a lot of them after 3-4 days do much better. Once they become very unwell, when they present and end up on a ventilator, the outcomes are very poor then.
And do you think that the earliest way of hypoxia detection is ask the patient to walk or talk and find out if there is a fall of more than 4% in the oxygen levels? I'm talking about exertional hypoxia much before resting hypoxia.
Yes.
Whether you walk or talk.
Yes, that is acceptable. In fact, we used to do that. But right now, we are finding patients more, coming a little later. So by the time they present, they are in early hypoxia. So you need to, in fact, what we advise is because of the shortage of beds and ventilation at this point, a lot of patients who present to us, we assess them. We ask them to buy a pulse oximeter, which they can use to monitor their oxygen saturations at home. And if they find that the saturation is dropping to 94% or less, then we ask them to come to hospital. Thereby, we can pick them up early. Until then, they can be managed at home without taking up hospital beds.
And when we talk about immunity, we have cellular immunity. So we have cellular respiration. So they start sleeping prone, self-proning, so that they increase opening up of the lateral and the posterior segment, which is much more common. And 2 is they start practicing parasympathetic, slower and deeper breathing, which we call them as pranayam, but they can call it as a parasympathetic breathing, which is slower and deeper breathing. 3rd is they can practice abdominothoracic breathing, so that they start learning opening up the whole lung. And then they give cellular immunity and cellular nutrition. So all 7 colors, 6 days, and add vitamin D, C, and zinc into their diet, either as a supplement or as orally. And then reduce the cellular stress by saying, so what if I get a COVID? I'm not going to die. So what? I'm talking about stress management. Yes, Ravan.
Yeah, I think I agree with you.
So what I am telling you is that everybody is afraid. They think that COVID means death, which is not correct. COVID means you may, because even simple pneumonia in these high-risk individuals is as risky. So if you detect, and we know the trigger, if you know early, if you can catch early hypoxia, you can reduce your mortality. And even then, if you die, in such cases in any way are high risk for any pneumonia or for any viral infections. So I come back to what do you do for your prevention? That will be all the doctors who are watching. They will like to know what are you doing for your prevention, and they should follow the same thing.
I think let me put it as 3 important things which everybody needs to do to protect themselves, apart from the staying healthy outside, your immune system, all that. One is ensuring that the infrastructure, I'm talking about the medical prevention. I'm not talking about for the lay person. I'm talking about doctors. In the hospital, you ensure physical distancing. you ensure that there is universal masking for you and the patient. In other words, you treat every person as a COVID case, irrespective of what the symptoms are. So you need to have infrastructural changes. In your outpatient, you may need to have better ventilation. You may need to physically distance the patient so that they stay at least 4 to 6 feet away from you, even in consultation. Do not examine the patients unless it is warranted, and wash your hands or use alcohol gel as soon as you touch the patient. So infrastructural changes are important. Second, access to knowledge and to personal protective equipment, and the importance of knowing how to use them. So you need to have the knowledge. I find, unfortunately, in a lot of government colleges in India, a lot of healthcare workers, in spite of having personal protective equipment, come down with COVID because they are not taught the correct way to use an N95 mask, for example. I find that normally you need to have a very tight fit when you use the N95. It should clearly come very close to your nose and hug the chin so that there is no air leakage. What I find is people wear the surgical mask, and on top of that, they wear an N95 mask with the presumed belief that it is more protective. When you wear an N95 on top of a surgical mask, it defeats the purpose of a close fit of an N95 and increases the risk, especially if there is aerosolization. So the second point, as I said, is the importance of correct knowledge and application to that. And third, and the most important, is the discipline. Unless I see people wearing a mask all the time, but when you go near and talk to somebody, you immediately pull the mask down and talk to him. That is because we are not used to the culture of masks. When we sit separately, the patient drags the chair forward and comes close to you to talk. You know, these are things which we are not used to, and we need to develop the discipline to ensure that we physically distance and use the mask appropriately. So if these three things are done, the rest is all usual. You know, have inadequate sleep, avoid smoking, drinking, ensure that you are, you stay stress-free, adult vaccinations, all that are usual.
Thank you, Dr. Ramasubramaniam. Quickly, I'll have a rapid fire because we have only a couple of minutes left. One person is talking about Zincovit or zinc-containing vitamin. Should I take it once or twice a day? Second is role of zinc in diabetes mellitus. And the third question comes is, can I be reinfected? Can zinc prevent my reinfection? Rainy season is coming. What to do? Go ahead.
A day zinc would suffice. We know that zinc helps in a lot of conditions, including diabetes and malnutrition. So zinc once a day is perfectly fine. Regarding reinfection, so far, we don't think it is reinfection. The test may turn positive, the RT-PCR, after 2 weeks, again, after becoming negative, but that is only showing dead virus, as I told you before. So far, we don't think there is reinfection unless there is a dramatic mutation whereby reinfection happened, but so far it hasn't happened. And thirdly, rainy season is coming. So we need to remember to take the flu shot as soon as the flu comes, because flu and COVID are very similar. Flu is preventable through the flu shot at least 70% of the time. So take your flu shot. Ensure, as I said, that a basic minimum of infection prevention by distancing and masks is carried out as part of a routine discipline.
So many people are asking about masking. Yesterday, I attended a seminar of WHO, and they came out with that there are only two types of masks, medical and non-medical. Non-medical, they are calling them as fabric masks. And when they are talking about a fabric mask, they have changed some guidelines, and they have said is that those people who are high risk, those people who are above the age of 65, those people who are caring for COVID patient should use a medical mask, not a fabric mask. That's a new thing which WHO has emphasized last night, because most of the people are using a simple cotton mask at home. And the second thing they have emphasized is even at home, when you use a fabric mask, it should be ideally 3-layered, outer layered hydrophobic, inner layer hydrophilic, and middle layer as a simple filter with that, which is slightly different from the surgical mask. Then the next question which comes is, how often such types of webinars are organized? As and when you want. What is multi-system inflammatory syndrome seen in children in Europe? Have we seen it in India? Have you seen it in Chennai?
I am not a pediatrician, but yes, we have seen anecdotal cases of what appears like Kawasaki syndrome. So this is a multi-system inflammatory disease, probably triggered by COVID, like a cytokine storm, and the treatment would be similar to you do for a Kawasaki. As I said, I personally haven't treated because I'm an adult physician, but yes, our hospital has seen a couple of cases.
And then they are talking about is difference between remdesivir and hydroxychloroquine. Can they be combined? When should they give? In India, it is still not available, likely to be available by end of this month. Currently, people are smuggling it from Bangladesh and still using it in many people. And the international recommendation is use it at the onset of hypoxia, early enough. If you give it late in the illness, it may not have an effect, like oseltamivir, where also we say use them in the first 48 hours. If you can't use it in the first 48 hours, at least give it at the onset of hypoxia. Therefore, it is very important to pick up hypoxia. Our own experience in Delhi and in Mumbai, when I speak to my colleagues, they all talk about hypoxia develops day 5, 6, or 7. So therefore, be vigilant and ask the people to start measuring their hypoxic level strictly day 5, 6, 7. And we have also seen it behaves like jaundice and dengue. In jaundice, fever disappears, jaundice appears. In dengue, fever disappears, and we start getting capillary leakage. Similarly, here, fever disappears, and you may start getting hypoxia. Just an observation. And they are still talking about should we add zinc in every patient of COVID-19, specifically with hydroxychloroquine? And herd immunity, what are your impression about herd immunity?
Regarding zinc, yes, I think zinc can be added to everybody. Hydroxychloroquine, the World Health Organization has now actually blocked the Solidarity trial arm where HCQS was used because there seems to be a lot of side effects, but we still have to see how it proceeds. Regarding herd immunity, when about 60 to 70% of the population develop immunity, the 30% within the same community are somehow inherently protected by the 70% immunity, 70% of people's immunity. To get to that level, even if you have a mortality of about 0.1%, we'll be losing millions of people. So I don't think it is practical to expect herd immunity to develop amongst us to protect the entire society. A vaccine is a better option.
So we have seen that in Italy, where the epicenter was there, they have now tested that 50% of the people have antibodies. That means in Italy, 50% of the people got infection. In New York, we have many studies which said that 25% of the people in New York got infection. So maybe that we require 20 to 50% of the people getting infection before the first wave will be over. I'm not talking about a herd immunity. And there is an ICMR query study which still has not been published, where they have noticed that in red zone areas, 15 to 30% people have shown antibiotic. Maybe we may get Delhi and Mumbai as the first one, where the first wave will be over, then Chennai, and then Ahmedabad, and then the wave continues in other states. It's like a wave of an ocean. It will not stop. It will come, it will stay, it will go to some other state. So all those states where the disease is not there, unless they practice social distancing and unless they reduce their density of population, these waves will continue. The time has come for urbanization of rural areas. And if you do that, and if you shift the density uniformly in the country, maybe you can stop or delay the waves into that. That's all for today. I thank Dr. Rama Subramaniam to be here with us. And I thank the Indus Pharmaceutical for sponsoring this and for supporting this seminar. And I say thank you to all our listeners all across the world who have been watching this. Kindly share the link with your colleagues so that the message goes all across the world. Folded hand, I thank you, Dr. Subramaniam.